you're in Washington, D.C. at TCT 16, and you know the appropriate length of dual antiplatelet therapy following PCI has been hotly debated in the last couple of years. In a paper in the October 25th issue of JACC, there is some compelling evidence that the ideal duration of DAPT most likely varies depending on procedural complexity. It's a topic we haven't really addressed for a while, so we thought we would invite one of the authors of this paper. It's Dr. Alaide Chieffo, who is the Director of Research at the San Raffaele Scientific Institute in Milan, Italy. First off, congratulations. The paper is really interesting. You're looking at the efficacy and safety of dual antiplatelet therapy after complex PCI. Why did you do this study in the first place?
Because I wanted to answer to a clinical question that I pose to myself when I treat my patient, because I'm an interventional cardiologist and I'm director of research in my unit. So all my research is trying to answer to my question, clinical question. So the point is that this is really a controversial field. There are different randomized clinical trials with different outcomes. It was published a DAPT trial saying that maybe we should extend. So I think that in interventional cardiology and in medicine in general, you should have tailored approach. So let's see really what is the need of prolonged dual antiplatelet therapy and in which subgroups, for example, complex PCI.
Yeah, we've talked a lot about the patients themselves and their characteristics, but to look at the characteristics of the procedure, I thought was really very good. So how did the design of the study work? What did you do in terms of designing this study?
So we were lucky to be chosen with we ran a security trial that was published a couple of years ago in JACC. And so it was asked to us by Tullio Palmerini to participate to this pool patient level analysis. So from that analysis that was run from 6 randomized clinical trials, including security, where we were leading authors, we collected so all the patients from the 6 clinical randomized trial, and we had all the data from the patient. And we specifically asked for this subgroup analysis to just look to complex PCI. We came up with our definition of complex PCI, which is quite extreme, but actually is reflecting our practice. For me, the complex PCI defined in the paper are exactly the complex PCI I do. So the definition was maybe a little bit different from other papers, but reflect our practice. So for us, more than 3 stents implanted, more than 3 lesions treated, more than 3 vessels treated, CTO, and a total stent length of equal or more of 60 millimeter, which is what is called full metal jacket, where the criteria that we choose for complexity of PCI. So these are quite complex PCI.
Now this is patient-level data in more than 9,000 patients randomized to different durations of DAPT after PCI. What did you find?
So what we found is that what we thought actually was true. So complexity of PCI matters because the more complex is a PCI and you need a longer duration of dual antiplatelet therapy. This for the efficacy endpoint, because we had the primary efficacy endpoint of MACE and a primary safety endpoint of major bleeding. And actually, if you have a complex PCI, that patient has an advantage in prolonged dual antiplatelet therapy as compared to a patient who has not a complex PCI performed. Indeed, on the bleeding, it's exactly the same. The complexity of PCI on bleeding extending the dual antiplatelet therapy does not make an impact. If you prolong dual antiplatelet therapy, you are paying this with major bleeding in both groups, if they are complex or not.
So these patients are high risk anyway, basically just because of the definition that you have, and they probably just require more time to heal. So is that another reason why the risk is so high with for these patients?
Yes, or maybe since these are more complex PCI, they have more comorbidities, they have also more progression of disease, and actually if you are on dual antiplatelet therapy, this has a protective effect.
And we probably should mention mostly new generation drug-eluting stents where you have about 85%. So it's current practice, so you were really these patients, you could consider them as current practice. Given your evidence that procedural complexity powerfully influences the benefits of longer duration DAPT, on the basis of your results and those from other studies, what's the lesson here in terms of care for post-PCI patients?
I mean, that when you're doing a complex PCI, most probably, but really complex PCI, how is it defined in our paper? Maybe in that subset of patient having more unfavorable lesion characteristics, most probably reflecting more unfavorable also clinical characteristics, you have to think to extend dual antiplatelet therapy. But this is only for ischemic event, again, because on the major bleeding, actually, it's the same thing. So you can risk to have a bleed because you are going to have a benefit on the ischemic event.
So in terms of, do you want to do any more? Do you want to do any other analyses, or are you pretty satisfied? What's next?
No, on this complex PCI, yes, but then other subgroup analyses actually have to be discussed with all the members and participants of the different clinical trials.
But it's pretty exciting, and congratulations, because I thought this was a very interesting paper. This is in the October 25th issue of JACC, so please look for that. At TCT, I'm Rick McGuire. I'm the executive editor of CardioSource World News and CardioSource World News Interventions.